I'm sure she might have forgotten, but in 2010, I was in a facility in UK to see what she was doing. So we've learned a lot, except that we are in a lower middle income country. But the dynamics should be the same. I have no conflict of interest. Pictures shown, and most of my presentations are picture oriented. A very different perspective from Caroline's, but most of the contents should be the same in terms of challenges. And a lot has come from our clinical experience. So for those who don't know where Ghana is, that is Ghana. And we are endowed. Look at the list of things we have as a country. So sometimes I wonder why we are lower middle income country. We have virtually all the things to make us very rich. So by way of just a bit an overview, we have fairly low incidence, about 1.67%. That's our prevalence rate. A total of 354,927 total number of people living with HIV, of which 7% are children. So in terms of adolescents, we have 10 to 19 years, a total, this is the whole country, about 21,000 plus, and young people 15 to 24, about 40,000 plus. The others are just for your information. So this is the model we run in the hospital is KATH, Komfo, Anokye. Prof was trying to mention a teaching hospital. It has a tradition, but that is where I operate, and that's where our clinic is based. So we run the 3-tier clinics from birth to 10 years, and it's normally held once a week. And then we have the purely adolescent clinic, normally held on Mondays. And then we have the transition clinic, we call it the young adult clinic, that we tend to operate with adult physicians, even though they are more pediatricians-led. So the good thing is it happens in the same space, in the same clinic. So we see each other happening. And then by maximum 24 years, 11 months, 25, you are purely in adult clinic. So 20 to 24, we tend to still have a lot of pediatric interest. But by 25, you should move to purely adult care. So by way of statistics, just the recent one I had before coming, we have 109. Again, data quality is a problem. And we only have viral loads which are for free. And there are instances where either there are no reagents or the machine is spoiled. We don't do CD4. All other tests, ancillary tests, are out of pocket. We don't have the quality information as we would need, but we're still using innovative way to do as much as we can. So for pediatrics, viral suppression is about 44%, and then for adolescents, 60.4%, and about 59.5% in terms of those who are viral load undetectable. So our model is to listen to the young people and adolescents as much as possible. So these are some of their own challenges, which really helps us to have models to help them solve the challenges they have as young people and adolescents. And so they talk about stigma, food insecurity, again, living with heavy burden. And then these were just expressed in their own language as the original letter you see, which was read by their leader. And they have a group headed by their own executives who they elect every 2 to 3 years to head them. And we are there to support them take decisions concerning themselves at the level of the clinic. So fear of disclosure, illegal state of disclosure, job creation, financial support, stigma, and discrimination. So one of the governance structures we have is we have a national constitution for them, which applies to all sets of, it depends on the level you are, but every clinic, and there are quite a number of separate clinics, can adapt the constitution. So our group has adapted, and the young ones you see at the time we took this were the young leaders, which sometimes made up of adolescents and also people between the 15 and 24 years old. And as at the gentleman on your extreme left, he was the president then, and he's now in his mid-30s and also mother to child. We have about 90% of our cohort being mother to child. Recently, we are getting a lot of young people who have had it through behavior, but they still add on to our clinics and we add on to our platforms, and they share the same benefits that they are for all of them as much as we can. And we also operate an advisory board which oversees the activities of the adolescent and young people, made up of parents, made up of so many volunteers from all walks of life. So you have teachers, we have nurses, we have, and of course, my country is highly religious, so we have the religious leaders, both Muslims and Christians, all parts of the leadership. And it is this same group that raises funds to support them. Because as I said, apart from viral load, a lot of the other supports we need to raise for them to keep them going. And there are grandmothers who are part of it because they've lost parents in between, and they all take part in the activities we undertake. And we have helped them establish their own welfare system where as much as you can or how much you can contribute, some contribute as little as $1 a month into a fund, which is there. So, and it's not compulsory, and you will still benefit from it if you have issues, but they make it as open as possible. So the board does support that by also raising funds to put it into an account. But this is just teaching them how to be responsible and taking care of themselves. So the leaders would often hint us if any of them have challenges, because they live with them in the communities and they're on the platforms with them. And once it comes to our attention, we're able to agree on to the extent to which we need to support them. So the picture there, one of their own who was in high school had hemiparesis and was at home. So they visited as a team, raised funds, and then we supported with also giving them addition based on the funds that we have in our joint account with them, so that they were able to visit and regularly support people who are disabled because of one reason or the other. She was otherwise well, but as to the reason why she got the paralysis, it hasn't been fully, but then there was a CT scan just to show that she has the problem within the CNS. So this is just a list of their contributions over the period of time. And what happens is we also identify people who cannot progress academically and have a plan for them in terms of putting them into trade and vocations as much as possible. So again, this decision will arrive at with the leaders of the young people and adolescents approaching the clinicians and our other board members, and then we'll sit together and then speak to the individual, whatever the type of job they want. So this young lady we had serially been supporting, and eventually in 2023, she qualified as a professional hairdresser because she had gone through the training, and I was around, so I was privileged to have been there during her graduation. So for almost 2014 to 2023, we were supporting her with her parents' consent so that she eventually got what she wanted. There's a gentleman at the top wearing 95. It's also one of them. He came to the clinic. You'll see his picture very soon. He is one of the main organizers. He's the one who puts up the announcement for monthly contribution, and then it comes into his account. And for accountability purposes, at the end of every 6 months, he will render account to us, which normally I'm part of it, and then we together will take the money into a joint account through credit union, which doesn't deduct, it doesn't take interest from it. So at least we are sure that it's not going to depreciate over time. Again, they are interested, and we support them take part or support their own in high schools. So they do visit them occasionally. When I have time, I also do visit because it's more of a community where we have a mapping of all those schools where they are training for high school, and then we do regular visits. This is one of the visits which they sent me the pictures after they had visited one of their young ones who is in high school in our setting. And again, yeah, there are occasions where I get involved myself. Churches do come in, other organizations, identify with them, come pray with them if the request is prayer, and then they make a lot of donations. And some members individually support those who want to do something. And once it goes beyond us, we appeal to the board members. And you would always get somebody saying, I'm happy to fund this person in the next 3 years to go through such and such vocation. Or to the extent that we have people who are being sponsored at the tertiary level, because we make plans for them, especially when their parents cannot afford. And adding on to the motivations, yearly we bring them together. We have what we call the Excellence Award for those who are doing very well at all levels of education. So last year, Those who graduated from the university, we awarded all of them with cash and then with some packages. And again, these were raised through our own community. And then those who finished high school, those who graduated from junior high school, senior high school, we just make sure that at the end of it, when the results are out, when those who do extremely well have a higher rating in terms of prizes, but virtually everybody who has graduated gets an award. And just a simple motivation, not too much, but something to show that we are there for you and we are there to support you go through your academic system if you are able to do that. And then we have a financial support. Again, some of them would need financial help. And we have a joint account, as I stated earlier. I'm a signatory, and one of their treasurers is also a signatory. So we come together, and then we look at the cost involved. If we had to do a series of labs, it will come to our attention. We cost it, we arrange with a lab, which would also give us some percentage. There's an arrangement, they reduce the price for us. So we put everything together just to make sure those who cannot afford are not disadvantaged. So renal function, liver function, full blood count, these are all regularly done. We pick the bill together and pay so that they are not disadvantaged. Having said that, some can also afford. So those ones, they don't necessarily benefit from the little account we have. I'm coming to an end. So this gentleman, as you saw earlier, started with us at 8 years, has gone through, he's now in the adults, fully transited, but he comes around to always support our clinic. And we have adherence issues with any of the youthful ones and the adolescent. He is now our focus, comes around to clinic and makes sure that he speaks to the person individually, using his own life as an example. We are not able to do sophisticated genotypes and everything, but these are clinical components we bring on board so that they come back to them. Any newly diagnosed person will refer it to one of our own who are on medication, and they help with the disclosure processes. So in conclusion, before a young adult transitions to full, we bring all stakeholders, and we have a huge board of virtually every possibility that you can think about to support them. And then as a team, we adequately equip the young person with the necessary attitude, knowledge, and skill to fully and successfully adapt to independent adult life. And I want to acknowledge the clinic. We do a lot of interventions within our own clinic, the staff, Pediatric Infectious Disease Clinic, and the National AIDS Control Program. Thank you very much.